Leena Mamilly from Nationwide Children's. I'm a pediatric endocrinologist, an assistant professor, and I'm going to be talking about our project for increasing urine microalbumin screening compliance in a pediatric or type 2 pediatric type 2 diabetes population. And I want to start by introducing our type 2 program. We have at Nationwide Children's a dedicated type 2 diabetes in youth program that was established in 2014. So before I joined Nationwide Children's by my colleague, Dr. Henry. And then we expanded in 2021 with ability to see more patients. We are a multidisciplinary clinic. We're also multi-specialty. We have a psychologist and a nephrologist on board. And we see patients for 2 sessions a month, and that's 6 patients for each of us. So it ends up being about 24 patients a month. And so you can imagine that this is not, the entire type 2 diabetes population at Nationwide Children's. So the rest of the patients are being seen in other general diabetes clinics, so alongside the type 1 diabetes patients and other types of diabetes. And then our type 2 diabetes patients who are only on metformin or in diabetes remission or going through a bariatric surgery journey, they are seen by our comprehensive weight management program, which is under general pediatrics. And so in order to reduce from the start, actually, in order to reduce the length of or the duration of the visits, we divided our visits into 2 types, visit A and visit B. So when they see Dr. Henry, they're seeing also a registered dietitian and a social worker alongside diabetes RN or LPN who rooms the patient. We have our diabetes nurses and LPNs are actually dedicated for type 2. So the patients are seeing almost always they're seeing the same faces, as they come in. And, we found that to be very helpful. And then visit B, which is my visit, they'll see the diabetes educator and therapeutic rec specialist. And then that's a person who addresses physical activity habits and, physical activity suggestions and this sort of thing. And then we have also a clinical pharmacist who helps us a lot. And so this slide, shows our data, but this is from a couple of years ago. I haven't had the chance to get more recent data. We've grown since, but we take care of a good number of type 2 diabetes patients, 171 unique patients, and that's only under endocrinology, so not encompassing maybe small pockets in other clinics. And our numbers are, demographics are very similar to, what you see in your, academic centers, where average age is 15, and then most of these kids identify as Black or African American, and then 30% are white and 15% Hispanic or Latino, and you can see that most of our patients are Medicaid insured. This is our team, and none of this work would be possible without them. Like I said, our patients see the exact same faces every time. My colleague, Dr. Henry, myself, and then Dr. Kalash is our nephrologist who staffs our clinic for to see patients who have high blood pressures or microalbuminuria or other situations, related to his specialty. And then we have our RNs and LPNs. On the left-hand side, in the bottom center, we have, this is our type 2 diabetes program coordinator. She's our admin who actually attends our clinics. She orchestrates the flow of the clinic visits so that patients are not sitting in the room, for a long time without seeing somebody. And then she will also help us in the upfront by calling patients and confirming appointments. And that's specifically for our type 2 diabetes program, so the dedicated clinic. And then we have our also quality improvement team. All right, so our metric, diabetes kidney disease, I don't have to, preach to this audience about how important it is to identify and address diabetes kidney disease. One of the most common complications in adults and children with type 2 diabetes. Search showed, shocking numbers of 20% incidence of diabetes kidney disease by 21 years of age. or I should say prevalence. And then this is also very, very tightly related to cardiovascular complications and mortality in individuals with type 2 diabetes. And so right now, what we are recommended to use is the urine microalbumin creatinine ratio screening at diagnosis, and annually, hopefully, we'll have better markers, as we discover them in the future. And this is one of the QI tools that we used is the effort impact grid. So we sat down, we came up with multiple things with the help of Melek, our QI coordinator. And I'm not going to read through this. I'll skip over to our key driver diagram. And after we met as a team, we identified a few of the key drivers. The key or the project aim was to increase the screening rates of microalbuminuria in youth with type 2 diabetes. We identified the age cutoff as less than 19 years, so 18 years or younger. Our baseline was 74%, and this is actually an improvement since we started the type 2 program. We used to be at the 60% or so. We increased it to 74%, but we wanted to increase it further and hopefully encompass everyone if possible. And so the key drivers that we identified were patient participation. So that's the biggest barrier, is you tell the patient to go to the lab and get the microalbumin done, but it doesn't happen. And then patient appointment adherence. So they have to show up to clinic in order for you to to recommend anything. And then staff practices. So a lot of times those tests were not being ordered. And then care access, which is a much bigger rock to move. All right. So we thought that the lowest hanging fruit was staff practices, because we have a specific team, and we could change those habits, or install new habits that are important. So one of the first things that we did is that we met with our team within a department-wide diabetes kind of CME platform, and we talked about the importance of microalbuminuria screening and the guidelines, and encouraged people to order, and we talked about what to do with a positive screen and that sort of thing. In the dedicated type 2 diabetes clinic, our clinic coordinator was pre-identifying patients. And one of the things that made it possible for an admin or a PCA, patient care assistant, to do that is that we have a care gaps space in Epic in the patient's chart that identifies a patient as due for that screen. This actually replaced multiple BPAs that we had before that were causing alarm fatigue. And so we replaced that with care gaps, and this helped identify those patients. We also enabled nurse ordering through licensed professional initiated protocol, so the nurses are able to place those orders without providers signing them. Oh, and then the signage also is a big thing, is that we posted signs for people to remember to send urine for microalbumin. In terms of patient participation, the intervention was very simple, but it was effective. We collected urine on everybody with type 2 diabetes as they were roomed. We gave them a water bottle to drink and then, go to the bathroom. And we told them that if it's not due, we're not going to send it. So that way we just tossed out the screens that did not need to be sent. And then we created also a mail kit for patients to get the urine done. If we had a follow-up, or they forgot to do it, then we send them this kit with like a sample cup, instructions on how to collect the urine, and then printed orders to take to their home lab. And this is the bigger side of things, which is appointment adherence. We have a coordinator, fortunately, but she can't work with all diabetes patients. But we do send automated reminders through Nationwide Children's Epic, and then they get phone calls, they get social work help if they can't get to their appointments, and then we partner also with Nationwide Children's Partners for Kids, which is an accountable care organization that's founded by Nationwide Children's for case management and to help patients get to their appointments and coordinate visits and help with that. Our current intervention is discussing FMLA with all parents of children with type 2 diabetes, because one of the biggest barriers is that parents can't bring them in because they think they'll be fired if they miss so many days of work. And so I don't think I have too much time, but I think this is the last slide, maybe. But yeah, so I mean, we met as a team. We created this updated KDD in the end of January of this year, and so far we've been seeing really good results. We had someone vet the results just to make sure that this is not because it did seem to be a very big improvement, and we're happy to see this exceeding our goal. So our next step would be to actually focus on other screens and add them onto this project, so that we have a screening bundle, if you will, for patients with type 2 diabetes. Make sure that we are adhering to guidelines and working with our nephrologists to create algorithms for what to do with a positive screen, so that people are not also hesitant about when to send the urine again and when to refer to nephrology. Thank you.
Hi, this is Anna from Rainbow in Cleveland. I think this is a really important, I feel like we really struggle because we have a lot of different satellite clinics to different sides of the city. And I think urine albumin, and then we had a lab change. So I feel like there's always issues with the urine. Like we can get the serum labs, but the urine has always been difficult. So I guess my question is, do you then have the family walk the urine over to the lab? Or is it someone like at the end, the MA takes all the urines over? Or what's that next step for you?
So the patient care assistants will walk it over, unless there is like an hour where the PCAs can't walk it over anymore, and then the parents have to take it. So we have a small refrigerator to store the samples, because they do have to be sent to the lab within an hour. Or I think 2 hours is the cutoff, because we're not sending a culture. So we usually take care of it. Rarely do I have to, because the time is too late, to have the family walk it over to the lab, which is in the same building as our clinic.
Hi, Jessica from Alabama. We also use the care gaps for a lot of our alerts, and I'm curious if a lot of your patients who you see for type 2 and other types of diabetes have primary care that are on the same Epic system. One time I had a pediatrician who ordered everything that was the care gap, routed the results to me and said, hey, it looked like this patient was due for it. And I was flabbergasted. It was amazing. And to me, that's the benefit of the care gaps and having primary care with access to that. I'm just curious if anybody anywhere has started to leverage with our primary care providers who are on the same network and platform.
That's a very important point, because those patients, sometimes patients live too far. Or they have barriers to coming into diabetes clinic, and we all know those patients have to go to if not weight management, a nephrologist, a gastroenterologist, or hepatologist. So multiple appointments, and we haven't really started. We're working with Partners for Kids. Again, this accountable care organization is also very quality improvement focused, and they work heavily with primary care pediatricians. So this is one of the next steps that we're thinking to take. Currently, we're working with them on improving metformin prescribing by primary care peds for patients with type 2 diabetes that don't need insulin or they're newly diagnosed. But yes, I agree that this is a very important point, and we have to leverage the technology and the EMR that we have to partner with primary care. Great point. I mean, I haven't seen that happen. I hope I do.
Thank you so much for presenting this. This is really exciting. Liz from University of Wisconsin. Question about care gaps. Is that the same thing as the health maintenance functionality, and is it tied to the problem list? And then the follow-up question as I approach my Epic team, what do I ask for in that? Do you have to set up the protocols, or does it pull in automatically based on the diagnosis? What does that process look like?
So I do think it's a problem list based. So this is what, what pulls it in is the problem list. And I wasn't involved in the build of this. I I weighed in, but I could certainly have or put you in touch with my colleague, who is actually our Epic liaison. My understanding is that it pulls up from the problem list. So, for example, when we have kids with type 2 diabetes and obesity, and they haven't been referred to the healthy weight center, or they have a high blood pressure, then all of these priorities are being listed under the care gaps. So I think whatever problems you put you can define what needs to be involved, what metrics need to be involved in the care gaps, and what defines those metrics. And this is how it works.
I'm really curious about your mail-in kits. How did you get that set up? And is there a vendor that you're using for them to mail it back to?
No, they are homemade. Our admin team, made we made we placed orders from our institution to, get the mailing supplies, and then our admin team helped put them together. You need them that much though. It's usually, probably 10% or so of the patients are coming back with a positive screen, and if you're able to get in touch with them and need that to happen. So they're not needed that much. They made maybe like 100 of them, and we haven't even gone through half of them. But yes, they are homemade. So the instructions say, I can just it's very small, but I can tell you, like, it says that the family needs to refrigerate the sample, and then take it to the lab. And ideally, if they're collecting it in the morning, then they have to take it to the lab within 2 hours of collecting. No, they don't mail it back. They collect it and they walk it over to the lab. Yeah. No, mailing it back will require, like, an ice pack, and it's kind of like transportation problems.